Thank you for having me here. I'm just here to talk to you guys about a pretty bread and butter iliac artery that's calcified. I'm just going to go through the case. Okay, here we go. So this patient was a 75-year-old female who came in with right-sided hip claudication. She initially actually presented at an outside hospital for an unrelated symptom, had a CAT scan that was suggestive of PAD, so she was referred to us. She did have non-invasive studies done at an outside facility with suggestive of possible right common iliac disease. Past medical history, as you see, the whole gamut, diabetes, hypertension. She had prior coronary disease, multiple interventions. Medication-wise, she was on dual antiplatelets and insulin and statins and things like that. So this is her, so given that her imaging was suggestive of right-sided disease, we went for left access, and this is the initial runoff. As you can see, very mild disease above the knee, good two-vessel runoff with some moderate disease below the knee. And this was the iliac angiogram. And as you can see, a very tight, focal, almost a type A lesion in the right common iliac, which is better appreciated in a contralateral oblique that's slightly magnified. Here you can appreciate the amount of calcium that's behind, and still the presence of a lumen, but a very tight channel. And this is the right-sided runoff. Again, pretty good, very minimal disease in the SFA and POP, and good three-vessel runoff on this side. I guess at this point I'll stop, and I'll have you think about what your approach would be. Would you treat this surgically? And if you're going to go for an endovascular approach, is your approach going to be ipsilateral, contralateral? What kind of sheath size would you use? Or would you try to even do this radially? And I'll let you think about that for a second.
Does anyone have any strong feelings that you want to shout out your answer?
Okay.
I definitely don't want A. I mean, surgeons, I don't think, are going to go for aortoiliac bypass. It's like practicing in the 80s.
So we'll just talk about that a little bit. Some data comes from limited data, but we have a meta-analysis from 2013 that did compare surgical versus endovascular therapies for iliac disease. And as you see, the patency overall is better with a surgical approach, but it's at the expense of higher mortality, higher length of stay, and more complications. And we also have data from this Bravissimo registry that shows, overall patencies almost above 85% at 2 years, and this is maintained through the different task lesions. So as of right now, as Dr. Han already mentioned, an endovascular approach first to iliac and most SFA lesions is usually what's recommended by this, a multi-society guideline. So some factors to consider when you're dealing with the iliacs is, as you see, the task classification is very helpful in kind of figuring out the severity and the extent of disease, whether it's involving the bifurcation, if it's a CTO, the length of the lesions. All of these kind of play into play when you're planning these interventions. But also, what becomes important when you have especially in the case of chronic total occlusions, you want to see if you have any major collaterals, especially if you're considering covered stents or things like that, any major branches or collaterals that are involved that might be jeopardized based on your intervention. So that's, and also the presence of any aneurysms, which can often happen with these lesions. Calcium overall complicates your intervention. We have a few different calcium scores that kind of categorize the extent of calcium overall. The more calcium you have, the more circumferential calcium. It's associated with lower patency and higher lumen loss. But it's also associated with suboptimal stent and balloon expansion, and also complications in the non-diseased portion of the artery. With a higher risk of dissections and perforations and things like that. So things to watch out. So in terms of procedural considerations, usually we tend to do dual access because one access you use for visualizing, and also you have it as a bailout in case you have a complication from it. You want to look at both your femorals and see if there's any concomitant disease in there as well, and also get good imaging. You want to really appreciate the full extent of the lesion, the eccentricity, and maybe even use EVS to look at the lesion and plan your sizing in terms of stents and things like that. And also, most importantly, I think having a good bailout strategy is really important, and having the equipment in the room, because you have very limited time. If you have a perforation or things like that, whether be familiar with the type of covered stents that are available at your institution, whether it's a balloon expandable, self-expandable, and what kind of sheath sizes and sheath compatibility that they go with. I think it's really important, and also having aortic occlusion balloons in the room when you're dealing with very calcified iliacs is really important. So we did obtain contralateral access in this case, and we took a better picture with a dual injection. So at this point, I have a question for you guys. How would you treat it? Would you use an atherectomy to modify the calcium? Would you use atherectomy, just angioplasty with an NC balloon, DCB, shockwave, or covered stent directly? Any thoughts? Okay. I see some proponents for shockwave, which is exactly what we did in this. So as you see on this, we have a 5 French UF catheter to visualize from the left side. And on the right side, we did initially cross with an 035 glide wire and exchange that to an 014 wire in anticipation of using a shockwave. And we used a 6060 shockwave balloon. Let me save this video. And as you see, as the balloon goes up, there's a tight waist where it doesn't. And after about 3 or 4 cycles, we got good expansion of the shockwave balloon. So if for those who are not familiar with this, it is one of the newer tools in our kit. It comes from urologic procedures, uses shockwave sonic pulses to fracture the calcium, that both intimal and medial. Comes in 2 catheter sizes. The M5 is for above the knee, and S4 is for below the knee procedures. And at least for the above the knee, there's a max of 300 pulses you can use per catheter. Just some preliminary data, basically pointing at better luminal patency with shockwave over balloon angioplasty, and I'll let you look at that. So this was our angiogram after shockwave. We had a pretty decent luminal gain, good flow, no real complications that we could appreciate. So at this point, would you take this result, or would you stent it? And if you were to stent it, what kind of stent would you prefer? And I'll just go over to the next. So comparing just balloon angioplasty to stenting, we have limited data, but at the same time, better patency with stenting compared to just balloon angioplasty. This was a meta-analysis that looked at about 6 studies over 4 years, basically showing about a 40% better patency with stent. And in terms of the different stents, we have a whole armamentarium of options, and people use different depending on their preference. And there's also, in case of bifurcation disease involving the aorta and the iliacs, there's several different techniques that have been proposed, including modified a simultaneous kissing stent versus like a V stent, and also a CRAB technique that we did a couple times over the live cases as well. And we also have an Endologix graft in addition to all of the different self-expanding and balloon expandable stents. The basic idea is that when you use balloon expandable stents, you can precisely land the stent in the area that you want, versus the self-expanding ones, even though they're flexible and they can be useful in a space where there's a lot of movement, they can they can jump basically, and your deployment may not be as precise as with a balloon expandable stent. And in terms of covered stent, usually in the case of any complications, perforations, obviously very useful to have them. And there's also some studies that show maybe they have better patency rates and freedom from TLR compared to uncovered stents. Just be familiar with the type of covered stents you have, and they're all pretty much comparable, but and be familiar with what you're going to use in case you need to. Just some data comparing the different types of stenting. The COBEST trial looked at covered stents versus bare metal stents, and found maybe slightly better patency rates with the covered stents at 5 years. And also the ICE trial, which looked at self-expanding stents versus balloon expandable stents, and found the primary endpoint was a little bit better with the self-expanding. And this was going back to our case. We actually ended up going with a bare metal stent, given the fact that we wanted to precisely land the stent, avoiding the aortic bifurcation. And we also were happy with the result we got with the Shockwave, and didn't feel like we needed a covered stent in this case. So we went with the 9.039 OmniLink. And this was the result after the stent. There was a discrepancy between the proximal and distal vessels. So we ended up taking a 12.020 and post-dilated the distal edge here. And this was our final. And that's it.